Yes, we stop share first, Budina.
Okay. All right. Is it possible to, when I want to open it, it can, when I share screen, it will go back to the same presentation? Is it possible?
Yes.
Yes.
Okay, I will try again.
Okay.
So I just go to this. Okay, fine, fine. Okay, Lisa, no problem.
Okay. We will wait until 10 o'clock in Indonesia,
Mm-hmm.
11 o'clock in Malaysia.
Okay.
How are you, Prof.
Fine,
Kamaliah?
fine, thank you. I just want to ask you all, we are having a colloquium for our students, for our REBM students, research and evidence-based medicine punya students, who would have finished their research projects. And therefore, we are doing a colloquium, asking them to present their research findings in the form of posters. We also have in oral presentations. So I was just wondering, are you all interested to send? Do you have any student projects that you all want to send?
Like call for
Uh, yeah, for the when it's at the time, the schedule, Prof.
It is next year,
Oh,
uh,
next year.
and it is going to be virtual.
online.
On what month? At what month?
Okay, then I have to go to the details.
Okay, okay.
Later, so, but
Okay.
we have interested in that event. Yeah, good evening.
I can connect with you later. So what I can do is I can write you all a letter so that we can invite you all,
Okay.
so that your students can participate in the research project.
Student and lecturer, Prof, or
Uh,
only?
lecturer pun boleh, no problem. Like for us, lecturers are involved in the students' projects, and therefore our name will also be there. It depends on how much we have written up the projects. Sometimes the lecturer is the first author, and sometimes the lecturer is the last author,
Okay.
depending on your university's, how shall I say, university's practice.
Okay. OMG. Yes, Prof.
Thank you
Like,
for the offering, Prof.
okay.
Talk about it later.
Okay, then so untuk hari ini, the lecture, it's okay to be in English?
Yes, it's no problem.
All right.
Before this, we have a lecture series with 3 professors.
Yes, from Melaka Manipal.
Okay, okay. Mm-hmm.
About public health and research.
Quantitative science.
What science, sorry?
Quantitative science.
Quantitative science. So research lah.
Yes, about cohort, cross-sectional, and descriptive statistics.
Mm-hmm.
Yes.
Okay, good. But I notice your students are arranged, yeah? Your students include preclinical as well as clinical students, yeah?
Yes, there is preclinical students here, and some of them in clinical students.
Mm-hmm. So what is their level of basic epidemiology?
Basic epidemiology in this semester, yeah, in this preclinic.
Research block in 3rd grade.
Okay. So meaning they already have some basics of epidemiology lah.
Yes.
Good, good, good. So I will, because if you notice, slide saya banyak sangat ya for a 1 hour lecture, and therefore I will skip some lah kot, so that it tends to be repetitive. So I was assuming that they don't have any basic EPID.
No, but it is okay to refresh all the knowledge, Prof.
Because I was thinking it would be more interesting if we relate it to our COVID-19.
Yes.
So that would be more something that they can appreciate because it is happening around them now. Yeah.
Yes.
And Indonesia actually has lots more cases than Malaysia. Yeah.
Yes, we are still facing this pandemic, Prof.
Berapa ribu kes sudah?
The apa? Almost 3,000 a day, Prof.
Oh, kami di sini sudah meningkat menjadi 1,000 cases sehari. Sudah banyak ya. So walaupun sebelum ini before the third wave it was double digit sahaja. Tapi sekarang ni sudah meningkat kepada 1,000 kes sehari, dan kematian kami pun in total cumulative telah melebihi 300 kematian. So our case fatality is still below 1% lah.
We hope this pandemic will be less. Lalu.
Orang kata the best optimistic picture pun, with the introduction of the vaccine next year, it will be till the end of 2021 before we see it being under control. Masih lama lagi. Masih perlu lama bersabar.
Yeah.
Yeah. Jadi students you pun tak boleh nak datang ke sini ya.
Yeah, Prof.
Students kami pun tak boleh pergi ke sana.
Tapi kita masih bisa online, Prof. Alhamdulillah.
But I don't know how you all find. Saya pun kami di sini online teaching. Tapi lain sikit lah engagement dia.
For clinical student, they still go to hospital, but have some rules and some restricted activities.
Kami di sini hospital, kerana hospital yang kami guna ialah hospital kerajaan, we have stopped completely going to the hospitals. So everything has to be online, and therefore we use macam case scenario ya untuk mengajar. Untuk nak mengambil, we have simulated cases. Tetapi untuk examination of patients itu terpaksa ditunda lah sampai kami boleh masuk ke hospital kemudian.
Clinical students 100% have online teaching.
Yes, right now, even now. Exams, kebanyakan exams pun dah online exams, except for the final clinical exam lah, yang itu kami tunda lah.
In our clinical, we offline, yeah, most of them offline, and we screening with rapid, or sometimes hospital need swab to screening our students.
But how often do you do your screening or swabbing?
Nggak sering ya, sometimes. Just in case maybe one students move from one hospital to other hospital, Prof.
I see.
Because we have 9 or 11 hospitals to our students.
Well, so far for us, they've just stopped. Jadi tak boleh masuk langsung ke hospital for our students.
mereka tidak boleh ke IGD.
Yes.
They can go to emergency room.
Tak boleh, langsung tak boleh.
Yes.
Because they are conserving our hospitals. Semua hospital menerima COVID-19 patients. However, we also need to continue our other services, non-COVID punya services. And because of that, there's a lot of space constraints. And the other issue is mereka takut jangkitan kepada pelajar kita lah. Because if that happens, then we will be held responsible lah untuk itu.
Okay. Prof, I read the news from the last 16 November. Yesterday, there are 467,000 COVID-19 in Indonesia with case fatality rate 3.3%. Still high, Prof.
Yes. For Malaysia, we are now fast approaching 50,000 cases. Fast approaching because setiap hari dalam 1,000 kes sekarang ni. It is still around 48,000 now, but it's approaching 50,000. And the deaths is 300 with a case fatality rate of 0.7.
Yes, 0.7.
But what is worrying is this is just the tip of the iceberg. Masih ramai kes yang belum di kesan ya.
Yeah,
so, what is worrying? Okay, lagi 2 minit ya sebelum kita mula ya.
Yeah.
Okay. You please direct me.
It's pleasure to meet
The
you.
meaning ini
Ya.
Koas sudah masuk belum ya?
Kok
Kayaknya belum.
Preklinik. Oke, wait.
Yang mahasiswa kan habis tutorial masuk sini. Koas ada nih. Teman-teman Koas sudah di sini belum? Dinyalakan saja nggak apa-apa, Dek. Unmute dulu, silahkan.
Ada, Dokter.
Oh, ini Pak Is. Ye, alhamdulillah. Kemudian ya beberapa mahasiswa yang S1 sudah setelah ini ya.
Oke. Assalamualaikum Dr. Yusuf.
Waalaikumsalam.
Dari tutorial terus ke sini.
Assalamualaikum, Prof.
Waalaikumsalam.
Prof. Kamaliah, this is Dr. Yusuf, the coordinator of public health block in preclinical student.
Okay. Orang yang penting ya.
Yes. It's very humble, Prof.
Terima kasih atas waktunya. Giving guest lecture for our program.
Terus Pak Yusuf.
Yeah. Maybe Cyberjaya pun patut menjemput ya profesor daripada Universiti Muhammadiyah untuk datang memberi guest lecture kepada kami ya.
Of course, Prof. Dr. Yusuf, siap. Or Dr. Burhan.
Oke, bisa mulai.
Yes.
Siswa ditunggu masuk semua atau dimulai?
Punya,
Bisa dimulai aja, Bro.
sudah 80% lebih kayaknya.
Sambil menunggu.
Kalau ya.
Mulai ya, Dr. Yusuf.
Ya, dimulai.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
First of all, let us pray and thank the presence of Allah Almighty for the abundance of grace and joy of all of us, so we can meet at this lecture, Visiting Professor. Not forgetting the salawat and greetings we pour out to the Prophet Muhammad Sallallahu Alaihi Wasallam. May we all get intercession on the end. My beloved students of Medical Faculty, UMS, Universitas Muhammadiyah Surakarta, and dear college lecturers, here we have visiting professor with the topic, the epidemiology of infection disease, that will be given by Associate Professor Dr. Kamaliah Muhammad MPH FAMM. I am Dr. Rahmadina from Sublab Parasitology, UMS, being your moderator today. This international lecture is held for the collaboration between Faculty of Medicine, Universitas Muhammadiyah Surakarta, Indonesia, Medicine, University of Cyberjaya, Associate Prof. Dr. Kamaliah. Assalamualaikum, Prof. Thank you for joining us today. As lecture series before, all participants must the voice speaker, but you can activate your camera. You can deliver your message, or you can ask direct later. The agenda for today of the lecture, main lecture, and then discussion, then closing. Now, let me introduce our lecture today. I will read the curriculum vitae of Professor Kamaliah. The full name is Kamaliah. Place of birth, Ipoh, Perak, Malaysia. Religion, Islam. Address, number 1, Jati 18H, Presin 18, Putrajaya. Nationality, Malaysian. Last education, MPH in 95 from University of Philippines, Manila. Last career, she is lecturer of Public Health and Community Medicine, Faculty of Medicine, UOC. For your information, MBChB is Bachelor of Medicine and Surgery degrees from the University of Alexandria. It is the same with medical doctor or MD in our country. And then she has FAMM. This is Fellow of Academy of Medicine Malaysia. And then she is a postgraduate diploma in dermatology from the University of London. Okay, and then we can proceed to lecture presentation. Please give your lecture presentation, Prof. Kamaliah. Thank you.
Okay, so I will share my screen, but it may take some seconds. Are you able to see the screen?
Yes, bro.
Okay. Right. So thank you so much, Prof. Madina, for that kind introduction. And thank you to UMS for inviting me to give this talk on the epidemiology of infectious diseases. And especially now when we are facing the pandemic of COVID-19, this topic is of special relevance. Yeah, and I've tried to present this lecture with application to COVID-19 so that you will be able to appreciate the importance of this subject right now. Okay. Now, okay, the outline, there'll be three parts to this lecture. One is the terms that we use in epidemiology of infectious diseases. Then I will spend some time on the transmission dynamics of infections. And last but not least, what would be this lecture without prevention and control measures that's needed? Okay. So for definition, for example, what do we mean by infectious disease? Rahmadina has mentioned about infection, yeah? However, in epidemiology, usually we'll be using the term communicable disease. It is interchangeable with infectious disease. And what it means is that this is an illness due to a specific infectious agent, or it can be its toxic product, like a toxin, yeah, that arises through transmission of that agent or its products from an infected person, animal, or reservoir to a susceptible host. Okay. And the transmission may be direct from person to person or indirect through an intermediate plant or animal host, vector, or the inanimate environment. Inanimate means it's not living, ya, tidak bernyawa. This in public health, you would have already seen this triangle. It's called the epidemiologic triangle. However, what I'm trying to show you in this epi triangle is that even though traditionally this epi triangle has been used to understand the host agent environment interaction for infectious disease, but now it has been expanded to even non-infectious diseases, injuries, non-communicable diseases, because the agents have now been expanded. Instead of limiting it to just biological agents, we also now have physical agents, mechanical agents, nutrient as agents. Yeah, so it has expanded. So this epi triangle now can be used for both infectious and non-infectious diseases. Okay, but I will spend more time on the epi triangle for infectious diseases. So in infectious diseases, this triangle is used to show you that you have many causes of a disease, of an infectious disease. It's a multi-causal model. Yeah, it's made up of three main parts: the agent, the host, and the environment. And these three must interact in order for infection to occur. Okay? And the agent, for example, must be capable of infecting the host. So the host must be susceptible. If he is immune, then he will not get the disease. And the environment actually is very important in determining whether it is favorable to the agent, as well as for transmission of the disease and the susceptibility of the host, which we will go into in the next few slides. So agents, what do we mean by agents? In infectious diseases, these are pathogens, and they can be divided into viruses, bacteria, protozoa, fungi. And these are necessary, but not sufficient to cause disease. Because sometimes, even though this agent is there, because the host is immune, you will not get the disease. So this is how agents are classified in infectious diseases. Now, the host factors, as I said, these are very important as well to determine whether someone gets a disease or not. Because the host sometimes can fight off the agent naturally due to his good health status, due to his immune status. We know that age is a factor. That is why, for example, it affects children and elderly. The adults usually are pretty strong to fight off infections. It is also dependent on whether the host has other diseases. So this is what we call the comorbidities. So for example, in COVID, you are seeing that the severe cases are happening in the elderly. They are happening among those with comorbidities like obesity, if they have diabetes, if they have underlying hypertension, underlying immunologic problems like cancers. Yeah. So this is an important factor as well. Nutrition. So you know that infectious diseases, if you have good nutrition, you may be able to fight off the agent and not develop any disease, as well as genetics. Yeah. Genetics play an important role in your susceptibility to an infectious disease. Like leprosy, for example, it tends to run in families, yeah, because the immunity is also genetically endowed, your cell-mediated immunity. Okay. So these are the host factors. Now we go to the environment. The environment, sometimes it's micro. So for example, for an agent to survive, it must need a right temperature. It must need the right nutrients. For example, in food poisoning, you have agents which are found in food, and if the food is the right temperature, then it can multiply. Yeah, so it can be micro. However, it can also be macro. So think big. It can refer to our physical environment. Climate conditions are very important. Why are there a rise globally in dengue, for example? It's because of warming, and therefore the vector is able to survive in countries. Last time they had no dengue, but now they are reporting cases of dengue, for example, in Japan. Yeah. So climate is important. Ecology is important. So, for example, in malaria, so if you human activity goes deeper and deeper into what was once jungle, where the Anopheles mosquito live, then you are introducing transmission because of those factors. Geography is very important as well. However, in our situation, the social environment is crucial. And I think you can see this from the COVID-19. If you look at the reports coming out from the US, for example, where they have documented that COVID-19 affects the various ethnic groups and the various socioeconomic status differently. So the case fatality, for example, is higher among the Blacks in the US. It's a relationship between poverty and the way that people live. If you stay in overcrowded conditions, yeah, in the urban centers, this gives you a higher likelihood of getting infectious diseases. So social environment is also very important. And as I said before, the agent environment, yeah, which I said earlier. So in COVID-19, let's look at its application in this epi triangle. Yeah, the agent is the SARS-CoV-2. That's the name of the virus. Yeah, it's a coronavirus. COVID-19 is the name of the disease. Yeah, but SARS-CoV-2 is the name of the virus. It infects humans as well as animals. Yeah, and in fact, they say that the origin of SARS-CoV-2 is actually bats. Yeah, and there must have been a spillover from bats. It went into a reservoir, another animal. Initially, they thought it was the pangolin, yeah, but that's not proven yet. And from the animal to humans. And then once it gets into the humans, then it spreads person to person. And the major mode of transmission is through respiratory droplets. And as I said earlier, the highest risk to get severe disease is older persons and those who are immunocompromised, as well as people with comorbidities. There may be other factors, yeah? How is the environment in COVID-19? It's worldwide. yeah, but it is influenced by political factors, social factors, demographic factors. So if your politician does not believe that you need to isolate cases and quarantine people who are being suspected, then it will be much more spread. So you see the differences between COVID-19, how it has spread in the Asian countries, the East Asian countries, especially as compared to the developed nations in the West. That's a function of politics and culture, yeah, and social factors. So this was taken from a recent publication to show you that the SARS-CoV-2, you can find that there is a very similar virus in bats. And that is why they say that SARS-CoV-2 probably originates in bats. And then it went to an intermediate host before it went to humans. So this is something that is evolving all the time. And they say that why host factors are important is because of the SARS-CoV-2, it latches on to the receptor, which is found in humans. And it is called the human angiotensin converting enzyme 2. So that is why in some people, it is easier for them to get infected. And that is why it's among the elderly and those who are people with underlying disease. And you have underlying health conditions that increase susceptibility to severe disease. So these are the ones that we have mentioned before. Yeah? So it has many proteins on its surface, which allows its transmission to human cells. And this is the immune response to SARS-CoV. And we need to understand this to know how the disease spreads. Yeah. So in SARS-CoV-2 transmission, it is noted that the virus replication is maximum in about a week. Okay, you have the most virus at that time, and then it starts to come down. And that is a pre-symptomatic stage. And in fact, from Malaysia, for example, we know that about 40 to 50% of the cases are asymptomatic. Yeah, 80% of the cases are mild infection. It is only the minority which goes on to severe cases. And if you look at, you see here. So if you look at the antibody level here, it only starts to appear very early, about 2 or 3 days after you get infected, and it gradually increases. All right. So if you were to do your antibody testing, then there may be a period where you miss getting the test correct. And that is why all over the world, we are using antigen testing. Okay. So the majority of people will have mild to moderate illness. As I said, in Malaysia, it's about 80%. But there's a number of people who develop severe illness, and some of them may even have to be admitted to ICU because it's life-threatening. So critical illness. In Malaysia, the policy is anyone who's positive is admitted. So even though you are asymptomatic, you will be admitted to hospital for isolation. Okay, but in some other countries, if you have mild disease, they allow you to stay at home. You isolate yourself at home, but only those severe cases will be admitted to the hospital for treatment. And therefore, in summary, when it comes to the epic triangle for COVID-19, you have the agent. And right now, the agent is everywhere. So there's community transmission already. And then, but you need to have host factors as well. And the environment is the environment where humans gather. And therefore, humans who go in crowded places, yeah, confined spaces, This is the environment where the disease can be transmitted. So that's the favorable environment for COVID-19. So some basic terminology for infectious diseases. So infection is the invasion of a host by the agent. Infectious, it refers to an infected host who's capable of transmitting infection. And an infectious disease is a set of physical and clinical symptoms present in an infectious host. They can result from direct pathology caused by the agent or by damage incurred by the host immune response. And this is what happens in certain diseases. Yeah. So what is important to remember is not all infections cause disease. Because as I said, it also depends on the environmental factors and the host factors. Yeah. So it's important to remember that. An agent causes symptoms, however, that favor transmission. So for example, in COVID-19, they develop cough. So when they develop cough, then respiratory droplets containing the virus is there. And therefore, this is the mode of spread. Yeah. In rabies, if you see, this is a rabid dog. He cannot swallow. His saliva is very infectious. He becomes mad, and therefore he becomes very aggressive, and he bites humans. So this is the symptoms actually is favorable to transmitting the disease. Therefore, this is something that you need to be aware of. Not all infections cause disease. Yeah. Now, the chain of infection in an infectious disease has three main parts. The first part is the agent is in a host or is in the reservoir. Okay, and this agent will need to leave the reservoir through the mode of transmission. And the mode of transmission, you can have direct contact, you can have droplets, okay? You can have a vector, for example, a mosquito here, a vehicle, for example, food, yeah? Or it can be airborne, yeah? And this is the mode of transmission. Through this mode of transmission, then it gets into a susceptible host. And this susceptible host has got many portals of entry. And depending on the disease, in COVID-19, for example, is respiratory. So it's through breathing in the air. However, you have other portals of entry. It can be the mouth. It can be syringes. Okay, you inject yourself. So this is important to understand in any infectious disease. It's very important to understand so that you can do prevention and control. And transmission occurs when the agent leaves the reservoir through a portal of exit, is conveyed by some mode of transmission, enters through an appropriate portal of entry to infect the susceptible host. And then this host can now become the reservoir and transmit to other people. So this is a very important diagram in order for you to understand the chain of infection and how we can break this chain of infection in our preventive and control measures. Other terms that I'd like to introduce, yeah, is the reservoir. What do we mean by a reservoir? It can be human or animal, and or the environment that is the habitat, the normal living space for that agent. So usually when that agent is inside this primary host species, it doesn't cause health problems to that species. So for example, the bat, he has COVID-19, the SARS-CoV-2 virus in the bat, it doesn't cause him any harm, all right? And then the vector is an organism that spreads the infection. So for dengue, for example, is mosquito, just like in malaria, yeah? It can be a flea, it can be a tick for other diseases as well. Or it can be an inanimate object. A fomite is an inanimate object that can be the vehicle for transmission. And this can also happen in COVID-19. So if someone does not practice personal hygiene and his hand is infected and he opens the doorknob, or presses the elevator buttons, and then someone else now presses the same. So that's by direct contact, but this is not the main mode of spread for COVID-19. It is important in diseases like rotavirus, for example. So the classification of communicable diseases or infectious diseases is via the clinical syndrome that it presents with. You can classify it by the mode of transmission. You can classify it by the method of prevention. And you can also have the major organism classification according to the agent just now, agent type, whether it's a viral, bacterial, fungal, or parasitic. However, by principal modes of transmission is more useful in the sense that this will help you to determine what would be the appropriate preventive and control measures. So by principal modes of transmission, it is divided into airborne. Airborne, there are two types, droplet or aerosol. So in COVID-19, it's droplet. Droplet are the bigger, when you sneeze or when you cough, when you talk, you have bigger droplets, which usually in about 1 meter will then fall to the ground. So you need to be very close to that person in order to be risk of transmission. Aerosol, it's finer particles. Yeah, it can go for a long distance. So, for example, they say TB is airborne aerosol. Okay. You also have by sexual contact, by physical, by blood and blood products, fecal oral route, foodborne, waterborne, through skin. That's transcutaneous. Yeah, it can be congenital from mother to fetus, and it can be healthcare associated. So, for example, in the hospital, you are at risk, for certain diseases is spread in our healthcare facilities. So actually, the classification of communicable diseases by principal modes of transmission, these are important to help us devise or design preventive and control measures. Yeah. Zoonosis is a disease initially transmitted from animals to people. So COVID-19 is an example. A spillover is when you have a single event, when a pathogen from one species moves into another species for the first time. And this spillover event, for example, when it jumps from bats or another animal to people for the first time. Now, Malaysia has documented one such spillover. That's the Nipah virus, yeah? And the Nipah virus was also found in bats and it infected pigs. And then pigs got disease, and then humans who took care of those pigs, the pig farms, then developed the disease. And it's a disease which has got a very high case fatality rate at that time. Yeah, and after the Malaysian experience, we have documented other Nipah virus infections in India, in Bangladesh, for example. Other countries have also reported Nipah virus. So this is a spillover, as they say. So COVID-19 also is a spillover from a reservoir, which is bats. It went to another host, intermediate host, another animal, before it went to humans. Yeah. So for transmission of COVID-19, these are the three possible modes. But as I said, the major one is the airborne through droplet infection. And these droplets can enter the mouths or the noses, okay, and it will be inhaled into the lungs. So droplets are large, short-range aerosols produced by sneezing. And look at this diagram, okay? And transmission is by direct spray over a few feet. They say about 6 feet, yeah, before the droplets fall to the ground. And that's why when we say, please make sure that you're at least 3 feet apart, 3 to 6 feet apart when you are talking to someone else. This is the reason why. So that is regarding the first part of my lecture, which is regarding the basic epidemiology of infectious diseases. Now we go and try to understand the transmission dynamics. And in this few slides, I'll be trying to tell you about what are the basic terms in transmission, yeah? And the main goal of this section is actually so that you can understand how we model infectious disease transmission. So first term that you need to understand is the basic reproductive number, also called R0 or R0. And this is the average number of secondary infections introduced by a single infected person into an entirely susceptible population. It's not actually a rate, yeah? It is just a concept. It's a number, and it has certain assumptions. The assumptions is that the infectious individuals is someone who is in that host, who will mix in that host population for the entire infectious period. That's one assumption, yeah? The other assumption is that everyone in that population is susceptible. And the third assumption is that the mixing of this infectious person in this population is homogeneous. Yeah, it's like any, the contact with others is the same as any other member of the population. And it also assumes that there's no interventions taken. Yeah. And if you look at this box, you find that from an infected person, if he spreads to 3 susceptible people, that will give you an R0 of 3, okay? And why it's important is that it represents an epidemic threshold. So if the R0 is more than 1, an epidemic is likely to occur. If it is less than 1, then it will die off. And if it is equal to 1, then you have an endemic disease, yeah, an endemic with a stable prevalence. So it's important to show how an infectious disease will spread in the population. And this is how you calculate it, right? It's depending on 3 things. One is beta, which is the transmission probability per contact. So like, for example, in COVID, it's aerosol or airborne, that transmission probability will be higher as compared to if it is by direct contact, yeah? And for number of contacts per unit, it also depending on how it is spread. And therefore, if it is by airborne, those people who are by droplet, for example, those who are 3 feet away will be your number of contacts, yeah? As compared to if it is by direct contact, you need to touch. So meaning one case will need to touch another person. So that's by if the transmission is by direct contact. So it is the number of contacts, it depends on the mode of transmission as well. And D is the duration of infectiousness. Actually, this is the 1 over the recovery rate. The D is equivalent to or equal to the inverse of the recovery rate, 1 over the recovery rate. And therefore, when we are calculating R0 or R0, it is the transmission probability divided by the recovery probability. So this makes sense when we think about if R naught is more than 1. If the probability of transmitting the infection is greater than the probability of recovering, then you will have an outbreak. Yeah, so it explains the epidemic threshold in the previous slide. So this is how you calculate R naught. Now, the duration of infectiousness, the D that we saw in the formula, is the amount of time that an infected host is infectious. And this depends on different diseases, yeah? Because in some diseases, it overlaps with the whole infectious period, and the infectious period. But in some, in the pre-symptomatic, they are not infectious, but then when they're symptomatic, then they become infectious. Okay. So hosts, sometimes when you are exposed to an agent, they are not yet infectious, but neither are they susceptible. So it depends on the disease whether you can transmit during the pre-symptomatic phase or not. And for COVID-19, we know that even the pre-symptomatic cases can be infectious, all right? So for example, in TB, this is an example taken for TB, you have latent TB, where you have the germ inside you, Mycobacterium TB in you, but it doesn't grow because your host immunity is pretty strong and your nutrition is good, your overall health status is good, right? And therefore, you can't spread it from person to person. Someone with latent TB doesn't spread it to another person. He's asymptomatic, yeah? However, when let's say your immunity goes down as you grow older, yeah, then this latent TB, this mycobacterium can now become active and grows in the body. And therefore you can have symptoms, you can have cough, and that's when it can spread from person to person. So when you talk about the duration of infectiousness, it depends on how the agent and the host interacts as well. And this will impact on the R naught. So these are the assumptions again that I have already mentioned, that the infectious individual spends the whole time in the population, which is not true, isn't it? When you fall down sick, usually you will stay in your room, you will isolate yourself. But some people, yes, they do go out. Now, mixing in the population is homogeneous. So this diagram is supposed to illustrate that. If you have a chemical which goes into this beaker of water, and then you shake it, then it's homogeneous, yeah, and therefore it assumes that the infectious person mixes with the whole population, yeah, and the mixing pattern of the initial infectious individual is identical to the mixing patterns in the population. This is an assumption, but it's very simple, isn't it? And therefore R naught is determined by the agent itself. Okay, it's also dependent on the host factors. It's also dependent on behavior, which is very important. Yeah, so especially in COVID-19, we can see that whether you maintain social distancing, for example, whether you will wear a mask. So that's host behavior. And it's also dependent on the population structure. Okay? Whether there are more elderly people, yeah, or whether there are more poor people. So that will determine the R naught. So how would an asymptomatic disease affect R naught? Would a large number of asymptomatic disease affect the transmission probability? It may lead to greater transmission probability, okay? And it is also associated because these asymptomatic cases, they feel very well, and therefore they go out into the community as usual. So he doesn't isolate himself. So that's why it can lead to higher transmission rates. How about virulence? Now, virulence is when you have a severe illness or death. Yeah, so an agent which can be very virulent causes very severe disease, causes a lot of deaths. So would severe illness change transmission probability? It depends on the disease, yeah, because increased virulence may lead to greater transmission, or it can be the other way around, lower transmission. What we can see in SARS, for example, in SARS, because they are so ill, immediately they are hospitalized and they are isolated, and therefore the transmission probability is less in someone who has a very severe disease as compared to COVID-19 if it's not virulent. So the majority of people are mild symptoms, 80%, or they can be asymptomatic, about 40 to 50%, and therefore they go out into the community as usual. Yeah. So high levels of virulence are often associated with high viral loads or increased secretions, and this may affect the transmission rate. It's also associated with changes in the person's behavior. So if you are hospitalized early, then your transmission is less. And this, it was in a recent paper as well when COVID still first came out. It's to compare the effect of transmissibility and severity on epidemic. And they were comparing influenza A, SARS-CoV, and MERS-CoV. This is the Middle Eastern syndrome, yeah? All caused by, the two are caused by coronavirus. Yeah? This is caused by the flu virus. So for influenza A, for example, in 2009 in the US, it was highly transmissible. By 1 month, it had spread to 41 states and 21 countries, but it was not severe. Okay, there was only about 200,000 deaths in the first year of the pandemic. And if you look at SARS-CoV, very limited number of cases, okay, about 8,000 cases, and the R0 was more than 2 in the beginning, but later it became less. There were only 700 deaths, okay, but because of the low number of cases, this gave a case fatality rate of about 10%. Okay. And high proportion of cases were severe. They were easier to identify and isolate. And the virus was present in the lower respiratory tract. Yeah. And therefore, it wasn't as easily expelled as compared to flu virus. Yeah. And MERS-CoV, very high severity as well, with a case fatality of almost 35%, but it had low transmissibility. Okay, so because of that, it's also limited now to certain countries, and it's not, it hasn't spread that much in Malaysia. Also, even though people went to the Middle East, mainly for Umrah and for Hajj, there were not that many cases of MERS-CoV reported. It had low transmissibility. Now, the other term that we have to remember is this effective reproduction number. Remember, R0 is when the whole population is susceptible. However, as the pandemic progresses, then you find that the susceptible population decreases. So at that time, then we are going to be talking about effective reproduction number, RT or R. So this is the average number of secondary infections that arise from a typical primary case during the entire course of his or her infectious period. So this is the difference that I was telling you about. It describes the reproductive rates as susceptibles are removed from the population. Okay, and how do you calculate it? It is R0 multiplied by the number of susceptibles divided by the population size. Okay, so when the RT drops below 1, the epidemic stops. Okay, this is why epidemics die out, because the number of susceptibles become less and less and are removed from the population. So why we do infectious disease modeling is because it's theoretical experiments. These are mathematical models, yeah? And however, the transmission mechanism must be known. If you don't know yet, then you need to analyze the outbreak further, okay? And disease modeling, the infectious disease modeling is limited to naturally occurring epidemics and endemics. And it complements our traditional methods because transmission interactions in a population are so complex, yeah, and therefore it becomes difficult for us to tell how the disease will spread. And the core of this mathematical modeling are contact rates and transmission probabilities. You need to know this in order to do your model. So for example, this is a model which looked at if your R naught is at levels of 0.3 or 1.5 or 2.2, what would be the number of cases? Okay. For example, if you implement social distancing or lockdown at one day as compared to the next day, you can tell whether the number of cases have increased, will increase by 40%, for example, if you delay your social distancing by one day. Now, the limitations of modeling is that it's an extreme simplification. Remember the assumptions that we had? So these are extremely simplified. It doesn't happen in real life. So the parameter values, they often have a high degree of uncertainty and inaccuracies. Yeah. And in epidemiology, I think what you also need to know is that the definitions and its principle, yeah, in epidemiology is a study of the distribution and determinants of health-related states or events, and the application of this study to the control. So the ultimate aim is to control these health problems. And these are the principles of epidemiology. That means to say it is a study, therefore it is scientific, right? It's data-driven. And then it is dependent on distribution. Therefore, we look at numbers, frequency, as well as patterns. We also look at determinants, not only the disease, but we look at determinants like causes and risk factors. And we have health-related states, not just diseases. You can use epidemiology for health-related states as well in specified populations. Yeah? And it is viewed as a whole, and it is applied. Okay, that's epidemiology. This is trying to show you descriptive epidemiology from the numbers that you have, right? You can do mapping by time, place, and person. Okay, and I will give you some examples. And from this descriptive epidemiology, then you will develop a hypothesis. If you don't know how the disease is transmitted, for example, how the epid is transmitting in the population, you can develop hypothesis for the source of the infection. Yeah. This is from a Malaysian infographic. They did a study on the cases so far of COVID-19. So they had about 6,000 cases. They found that 30% are symptomatic, but with no pneumonia. They have 13.6% has got pneumonia without difficulty in breathing. And then 3.5%, they have pneumonia with difficulty in breathing. 1.1% are critical. They need to be intubated. 50% were asymptomatic. So this is regarding the cases of COVID-19 in Malaysia, because in Malaysia, even the asymptomatic will be admitted to the ward. So that's how they got this. So this is a descriptive epidemiology of cases of COVID-19. And what is important to note is that half of them were asymptomatic. Yeah, therefore you don't know whether the person next to you in the mall is COVID-19 positive or not, because he has no symptoms. And that is why the health education message is wear a mask when you are in a public place. Yeah. This was an earlier one where you can look at by age group, by gender, whether they are imported cases or local cases. At the beginning, we were talking about travel history. So did they travel to Wuhan, or was it to any part of China? Or we had one case who was from Singapore, for example, he traveled to Singapore. And you can also categorize your cases in terms of close contact or uh, under investigation, person under investigation, or those who were brought back from overseas. This is the humanitarian mission, and you can also look by nationality. Okay. Now, what's important in epidemiology is to note that rates are more important than numbers. So if you look at this graph, this is the number of cases by age. However, when you plot it by rates, so age-specific rates, you'll find that the 55 to 59, above 55, have got higher rates as compared to, if you look here, you find that the 180 and 182, 180 is also among the younger age group. Okay, so it's important to put things in perspective. Epid patterns. This is your epid curves here, which can help you to determine the spread of the outbreak. Okay, and the spread can be common source, propagated, mixed, or other. And the common source is further subdivided into point source, for example, in food poisoning. Yeah, you have one source within one incubation period, you have a peak of cases and then it comes down. However, when it's continuous, then you find that it's the same source. However, it's like a plateau. It goes up slowly and then plateaus. So this is the persistent source. For example, if you have a well, okay, which is infected with, let me see, Vibrio cholera, for example, and then you have different people coming to the wells every day, and therefore that's a common source. However, it is over a period of time, so it's continuous. And intermittent, it's also like that. It's just that you have different peaks over a spread of time. Propagated is human to human. So for example, measles, that's a propagated source, and it goes over a long period of time. It has got peaks according to the incubation period as well. Okay. Let's look at COVID-19. This is what the epid curve of the confirmed cases in China, in Wuhan. Yeah, and what they've done is, in the beginning, in December, it was very few cases. Okay, and then it started to rise in January. And if you can see, there are two colors here. This is because the blue one is by date of onset of symptoms, which is your epid curve is usually plotted by date of onset. And the ones in yellow is by date of notification or date of report, date of diagnosis, okay? And you find that there's a lag. There's a time lag between date of onset and date of reporting, date of notification. And when you have a case like COVID-19 where a lot are asymptomatic, you find that most people will not be able to plot the epid curve based on this date of onset of symptoms, but it will be based on the date of notification or date of reporting. So what you are seeing right now is actually a few weeks old, okay? And what they've done is try to plot the events, yeah, of the pandemic, where initially it was in the seafood market. Once they have done that, then they realized that they needed to inform the WHO regarding this new outbreak, because it was a new virus. and then the reported cases among healthcare workers only came about somewhere January 20th, for example. So once they know that there is human to human transmission, then it becomes more serious. Initially, they thought it was zoonotic, right? So then at about January 20th, that's human to human transmission. And so they say that it's a really dangerous situation in terms of the outbreak. And the WHO declared the COVID-19 as a public health emergency of international concern on January 30th. Okay. So this is an epic curve of COVID-19 in China. Now this is the Malaysian epic curve. Okay, but this is from the beginning until now. Okay, and there was a pre-pandemic period where the baseline was 0. Okay, and then we had our first wave where we had imported cases, Chinese tourists who came in. We also had a local Malaysian who went to Singapore for a conference, and his colleagues were also from mainland China. And when he came back, then he was found positive, and he transmitted it to his family members because it was Chinese New Year at that time. Okay. The second wave, we had clusters, whether it was at the religious gathering or whether it was at meetings, yeah. And we also have clusters in our immigration depots, yeah, where we have a lot of immigrants who were captured and then put into these depots, and the condition is very overcrowded, and therefore we also had clusters. So this is the second wave was clusters, yeah. And then we were relatively good over a period of time. Okay, however, in September, that's when we have our third wave. And this wave is really massive in the sense that the number of cases has really gone up. They had to impose another lockdown. A lockdown was imposed at the beginning in March and April, and now they are having another lockdown during this time. Yeah. However, the number of cases still seem to be increasing. And I don't know actually how long it will take before it will come down again. So for example, the second wave, it took about 4 months, yeah, for it to come down. So this time around, we've yet to see, okay? So globally, I've tried to get this from the dashboard of the WHO for Indonesia. This was as of 13th of November, about 450,000 cases cumulative. You have about 4,000 cases a day now, and you have about almost 15,000 deaths, okay? And new deaths in a day is about just under 100. So you're classified as community transmission. Malaysia is down here, it's about 43,000 cases, or now today is 48 already, yesterday. About more than 1,000 cases reported daily. We have about 300 deaths, and deaths can be 1 to 3 to 5, okay? And it's still considered as clusters of cases, even though we say there's actually already community transmission. But we cannot compare to other countries which are really huge problem, for example, in the US, yeah? Okay, prevention and control. In order to understand prevention and control for infectious diseases, we relate it to the natural history of disease. Okay, so for example, primary prevention is related to the pre-pathogenesis stage of infection, where you don't have any disease yet. Secondary prevention is related to the pathogenesis stage of infection, where the agent is already in the body. However, it may be still asymptomatic, what we call COVID disease, during the incubation period, and then it expresses itself as overt disease, and then after that, either you end up as a death or you can cure completely, or sometimes you are cured but you have some impairment. So that's the post-pathogenesis impairment where you need rehabilitation services, and that's called tertiary prevention. Okay. So this is the relationship between the phases of prevention and control with the natural history of disease. And if you look at infectious diseases historically, even public health measures like safe water and sanitation can reduce the number of infectious diseases in a community, in a population. This is in the US when they first started using chlorine in water, all right? And then when antibiotics came in, when vaccines came in, so it reduces the infectious diseases burden in a population. So strategies for the control of epidemics due to communicable diseases based on that chain of transmission, yeah? You attack the source, you interrupt the transmission, or you protect the susceptible people. And there can be many strategies for this. And therefore, if I can look into some of the strategies that have been taken, vaccination is one of the most effective and cost-effective ways of controlling infectious diseases. So the vaccine preventable diseases, like for example, we have managed to eradicate smallpox. Yeah. You also have environmental measures, safe water and vector control. You also need to look at human behavior, and therefore you need to teach people about hygiene, for example, yeah, self-care, self-protection. Animal and food control becoming more important because infectious disease outbreaks now are mainly zoonotics. Yeah. Case finding and treatment is very important as well, and occupational measures because you need to protect people exposed at the place of work. Yeah. So for COVID-19, box in the virus. So you need to detect cases early, okay? And once you detect them, you isolate them, or you quarantine those who are not yet ill but are contacts. Yeah, you do testing, isolate them, identify the contacts, quarantine the contacts. So you need to box in the virus. This is contact tracing, yeah, for infectious diseases. We can change the epidemiology of infectious diseases. For example, I mentioned smallpox, we have managed to eradicate. Vaccination has reduced. You know that there's a new Ebola vaccine now, which is available, yeah? Measles, mumps, and rubella, that's why the numbers have gone down so much. Influenza is a little bit difficult because every 6 months you have to change the vaccine, yeah? Drug treatment, and also the most important actually is the education, behavior changes, laws, and policy. And that's why in COVID-19, this is especially important. This is to show you the effect of introduction of Haemophilus influenza type B vaccine on the severe HIV, meningitis, yeah, and sepsis. So within a space of about 5 years, they've managed to reduce it. And the use of drugs. So for example, for HIV now, they say that using drugs to treatment is actually prevention because you can stop the transmission of HIV when you treat cases. Okay. And this is also to tell you the fact that actually hygiene, personal hygiene, social distancing measures will be able to block transmission of COVID-19, for example. Yeah. Just like early testing and isolation will be able to prevent COVID-19. COVID-19 has no vaccine yet, even though there are some which they say are safe now and we should be able to get it by next year. Okay, but then before we have the vaccine, then we will still need to make sure that transmission is interrupted through the social distancing, personal hygiene, changing of human behavior. Yeah, and this is to tell you the comparison of the R naught of diseases. So measles, for example, the R naught is very high. Yeah, as compared to MERS, the R naught is less than 1. Okay, that's why it doesn't spread. And the concept of herd immunity is to tell you that when you have an infection in the population, you will have people who are exposed, you will get an increase in number of cases, and then you come to a stage where it's called herd immunity because the number of susceptibles has come up so much, then the outbreak comes down. Okay, and this is a graphic to show you that the top one is if you don't have any immunity in the population, so what we call a naive population, as compared to a population which has got herd immunity. Even though you have a case, it will not be able to transmit. Okay, I think this is about the same thing as well. How do you determine what would be the level needed, yeah, before you can establish herd immunity? Therefore, you go to your models, your transmission dynamics, to look at the R naughts, yeah, to make sure that if it is below 1, then the epidemic cannot occur. Most of the time, 70, 75, 80%. Okay. So this is another, I'm coming to the end of my slides already. I think it's important for us to know why is this called a pandemic. Is because it has spread over several countries and continents, as compared to an outbreak or an epidemic is usually in a localized area. Okay. These are the public health implications for COVID-19. We are still dependent on the traditional public health outbreak response tactics. Yeah. So for COVID-19, until we have the vaccine in place, this will continue. And they say that it's probably until the end of next year. Globally, this is what the WHO is saying in terms of the objectives for their response. One, they want to limit human-to-human transmission, and therefore they are still depending on the traditional public health measures in terms of COVID-19. And the response depends on the stage. In the beginning, for example, we want to prevent export and import. So Malaysia also closed its borders. Second phase, you want to reduce the intensity. You want to slow down the increase in cases. That's why we use the traditional public health response tactics. And thirdly, you want to reduce clusters of cases, as what we are seeing right now. And you need to strike a balance between epidemic prevention and the economic and social impact of the epidemic. Yeah. So this you can only do if you have scientific evidence, and then your policy must be based on this scientific evidence. Then only people can accept this public health response, which is so devastating on the economy. So I mentioned just now about the WHO, first of all, through the International Health Regulations of 2005, an outbreak which they think can spread to other parts of the world, then they declare it as an emergency of international concern. And this shows you a very good picture of what are the preventive measures and the control measures when it comes to COVID-19 in China. If you look at the brown boxes here, this is they wanted to control the source of infection through medical resources, yeah, and then they want to block the transmission route, yeah, through lockdowns, yeah. This is the blue one. And prevent new infections through personal hygiene. These are the individual measures that people can take, yeah. So these are the preventive measures for COVID-19 over the course of the outbreak in China. And this slide is to show you now, for example, the Oxford Observatory, they are looking at relationship between government response and the number of cases. Malaysia is here. So the stringency level, whether your lockdowns and all that, is about 70%. Indonesia is here. Indonesia is about 50 something percent. Okay. And our number of cases is here and Indonesia is here. So the higher you are over here, then the higher the number of cases. Here is the more stringent your response is. So if you look at the global picture, you find that very stringent are the Asian countries, yeah, but here you have one as well in Latin America. However, in the developed countries, they're not so strict, okay? Globally, more than 50 million cases, more than 1.3 million deaths. And I think this will be the last slide on the critical lessons that we have learned. You must have a strong health system which is resilient. Leadership and public trust are the single greatest indicator of success. Okay. Defend the integrity of science and public health agencies. These are lessons learned from the US. Yeah. Invest in biomedical research and development, for example, vaccines. Focus on equity because COVID-19 has really shown the world how inequitable the population is in terms of getting COVID-19 and dying from COVID-19. And adopt evidence-based laws, safeguard the rule of law, and fund and support robust global institutions because we are in this together, whether we're in Malaysia or Indonesia, we are all bound together, yeah, in fighting this pandemic. So with that, I'd like to end my lecture and maybe we can have time for discussion. Thank you so much.
Thank you, Prof. Everybody. Yes, it was very interesting lecture. We can learn about definition of terms in infection, then epidemiological triangle, and then Ernol or basic reproduction number and RT, and then about COVID-19 globally, prevention and control of infectious diseases. Now we step to discussion. I have opened the chat and in chat room there's no question, and so please you can ask the question directly in this Zoom meeting. You can unmute directly and then ask for a question right here. Is there any? If there is, maybe not yet. I will ask first. I have a question about dengue fever, Prof.
Yes.
Yes, we in Indonesia and Malaysia, I think dengue fever is still a problem. We in Malaysia, there is a system of e-dengue. I have heard about it, but in Indonesia we have a system informasi, but not for dengue. It's for malaria. We call it SISMAL, System Informasi Surveillance Malaria. How about e-dengue in Malaysia? How effective that system to lower the transmission of dengue? Thank you.
Thank you, Ramadina. It's important to realize that one of the tools in control of infectious diseases, it's surveillance. You need to know your disease in terms of person, place, and time, so that you can have targeted responses. Okay. Now, using of information systems, it's the use of technology of IT to help us in doing surveillance. For Malaysia, when it comes to infectious diseases, all notification of infectious diseases is now done through a system, an online system called e-notifikasi, notification of infectious diseases. So any doctor in the government or in the private, they can access that system when they have to notify any infectious disease. So when you use technology, you cut short the communication delay if it was done through paper, okay? And e-dengue is a further development of the system to see where the cases are and what are the control measures that have been taken. So it's not only where is the case, when was it notified. It also tells you whether the district has already taken measures to investigate the case, and after they investigate the case, what were the control measures that they have taken. So e-dengue is sort of a complete system from notification until the control of the case. And from this system, we can tell whether the case has been appropriately investigated in time and whether the control measures were appropriate for this case. So that is e-dengue. And I guess if you have a big problem of malaria, you would do the same. But not all diseases in Malaysia will have this complete system of from notification until control measures have been taken. Yeah, but all the infectious diseases for surveillance purpose is now using this online platform called e-notifikasi, so that we can at least tell by person, place, and time where these diseases are. It is important to have surveillance in public health so that we are able to take measures, targeted measures for infectious diseases.
Thank you, Prof. Kamaliah. It's very interesting. Okay, please.
I want to ask Dr. Romadina.
Okay, please, Dr. Nining.
Okay, Prof. Kamaliah, do you think that in Indonesia the case fatality rate for COVID is higher? It's 3.3%. It is because of the case reported lower than reality, or what do you think, Prof? And then the second, in your presentation, you said that we can change infection disease epidemiology by eradication, vaccination, drug treatment, education, behavioral changes. What is the most effective? Especially in our country, the community, not all of them are disciplined, Prof. Thank you.
Thank you. Yes, Ning, I think that's a very important point because case fatality rate, the formula is the number of deaths divided by the number of infections. So if you do not detect enough cases, yeah, then that's one of the possible reasons why your fatality rate is higher, because you don't detect enough cases. Yeah. The other possibility is the disease is severe, okay, but looking at the uh, the deaths worldwide, we know that you have to look at host factors, and therefore you do need to see whether the deaths in Indonesia, are they among the elderly, are they among those with comorbidities. Okay, for example, here in Malaysia, we are very worried because our population has a very high prevalence of non-communicable diseases. Our diabetes is 18% of the population. Hypertension is more than 30% of the population. And that's why for us, we are very worried that this group of people who have comorbidities, if they get COVID-19, then our deaths are going to go up. But so far, we haven't seen it, all right? I think the third point that you have to look at is the capacity of your healthcare services. So in certain countries, when the ICU beds gets overwhelmed and you don't have enough, yeah, then you will have higher deaths as compared to a country where the ICU beds are enough, for example, to take care of the severe cases. And therefore, you need to also look at the capacity of your healthcare system in terms of responding to severe cases of COVID. It's not only severe cases of COVID, also your primary healthcare. Can they detect cases early? So the capacity of your healthcare system is very important as well. And that is why at the beginning, they say we should take all measures to flatten the EPID curve so that it gives time for your healthcare system to prepare for the next wave. And that is why, for example, in China, they managed to increase the number of hospital beds in about 3 weeks. Yeah. So it is important and an important aspect when we are talking about case fatality rate. Yeah. Now, what would be the most effective measures? I think you know the answer to this one, isn't it? It will have to be a mix. Yeah, it will have to be a mix. In terms of COVID-19, in terms of treatment, there's only supportive treatment for those severe cases. In terms of health education, making the people understand that they need to be cooperative in social distancing. It's probably a problem of our communication, our lack of communication on how to inform the public. And that's why they say in this, you need to have communication experts. You need to have behavioral scientists to be able to give this message in such a way that people understand that it is really important for them to practice social distancing and to wear masks. And for us in public health, we always say, don't blame the victim. Yeah. So it's not that our people are not disciplined. It's just that they have not, their level of awareness has not been increased to such a level that they need to take these measures. These are very difficult, unpopular measures. And that's why in certain countries, for example, even in Malaysia, we use a lot of the social media to reach people fast and effectively, right? So I think the way we communicate needs to be relooked. The use of the messages that need to be taken out. For example, in Malaysia right now, what you are seeing right now is a lot of backlash in terms of the current lockdown. People are discussing openly, why should we be having a lockdown right now? Okay, and the only way to overcome this lack of trust is actually to engage more. The government needs to engage more with civil society and bringing it to a level that even the people in the street will be able to understand these measures. Yeah. It's difficult, of course, yeah, but it is something that we need to do if we don't want to see our country become like the US, for example.
Okay. Thank you, Prof.
Thank you.
Okay. Is there any question from our students? Sabrina?
Excuse me, chapter.
Okay, please.
Oh,
Sri Harnani.
hello, Prof. I would like to ask about the 7 critical lessons. In one of its points, it said that we should invest in biomedical research and development For example, rapid testing. As we know that COVID-19 patients is mostly has no symptoms, and as medical workers, is it really important to us to do rapid testing regularly? Thank you.
Yes. Yeah, that's true. For example, if you look at the historical response in Malaysia, for example, in the in the first week, when China put out the genomics of the virus, so we had to develop our test kits. Yeah. However, it was just like 3,000 a day that we could do, but now we have increased it to about in the second wave we could increase it to 50,000 tests a day, right? And therefore you need to have this capacity, this ability to increase your testing capability by development of kits. Yeah. In countries like Korea, for example, they allowed the private sector, they had private companies to produce these kits without too much of a bureaucracy in terms of testing. They have their, the approval mechanism. They managed to shorten it. But it is important to note that you must not sacrifice quality for the sake of time. As can be seen for some of the kits that were bought in the beginning, produced by China, I think, where it could not be used because they were not sensitive and specific enough. So it is important to remember that you need to have this capability of producing test kits, for example, which will meet the needs. Yeah. Yes, you are right. The majority of, a big proportion in Malaysia, for example, half of them are asymptomatic. And therefore, how do you test? How can you test? So for example, in a state like Sarawak, people who come from Peninsular Malaysia now, when you go to Sarawak, you will have to be tested. You have to be tested within 3 days before your flight to go into Sarawak. And when you reach Sarawak, they will do a swab on you. So it depends on the situation. Sarawak, because last time they didn't have that many cases when Peninsular Malaysia had so many cases. So they wanted to protect themselves, from the spread of COVID-19 into the country. So as healthcare workers, you are going to be working in a situation in the hospital, for example, or in the clinic where you have a higher risk. However, remember that healthcare workers also are very aware of the importance of protecting themselves using personal protective equipment, right? So frankly speaking, if you're working in the COVID-19 ward, you're probably safer than if you are working in the emergency department, because the emergency department receives all types of cases, right? So you don't know which one is positive. And therefore, you as a healthcare worker, the first thing you have to do is to make sure that you have PPE to protect yourself. However, in the Malaysian hospitals, if you have been exposed, even though you're wearing PPE, but if there have been a positive case that you have been in contact with, then they will do a swab on you. And they will ask you to be quarantined at home until your swab comes back twice negative, then you can start work again. At the same time, if you have any symptom, even though you are not in contact with any COVID-19 case, but if you're symptomatic, let's say you have a running nose and you have cough, you have fever, they will do a swab again on you because you are a healthcare worker. All right. So for healthcare workers, it's a little bit different. On the management to make sure that they are not COVID-19 positive. So that's one thing. But then for the general public, To me, if you think that you could have been exposed, that's why in Malaysia we have this app called the My Sejahtera app, which tells you when you go, let's say, to a mall, it will tell you whether this is a safe place, right? And if there have been cases which is positive who went to that same mall, this app will allow the health department to know who are the others who came to that mall who should be considered as contacts. And therefore, then only we will do the testing for this context of this case. Yeah. So it's important in contact tracing, if you have the technology to detect cases early, to detect the contacts early, then it will help you in your fight against COVID-19.
Thank you, Prof.
Thank you.
Thank you. Prof, she is a clinical student.
Okay.
Okay. I think this is 11:20. Is there any question? No. Prof, I think this is the end of this lecture, everybody. Well, I hope this lecture can enhance the knowledge of our beloved students in pre-clinic or clinical students, especially from global perspectives. Everybody have important role to play global health and Indonesia. I apologize if there is mistake at this event. Thank you for your participation and dedication all. Thank you, Prof. Kamaliah. Nice to meet you, and I hope we can meet again. Okay, please fill the G form for the certificate of attendance. Now we can close with doa kafaratul majlis. Subhanakallahumma wa bihamdika asyhadu alla ilaha illallah asyhadu alla ilaha illa anta astaghfiruka wa atubu ilaik. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Terima kasih banyak dokter.
Ya, makasih.
Terima
Waalaikumsalam.
kasih dokter Kamila.
Sama-sama, my pleasure. Jumpa lagi.
Terima kasih dokter.
Kapan-kapan kita nyobain nasi lemak lagi ya, Budin.
Iya.
Okay.
Dr. Yusuf, matur nuwun. Thank you, Prof.
Thank you so much. Assalamualaikum semua.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Budina.
Yes, sami-sami.
Mohon maaf Bu Neneng, tadi saya lupa.
Apa, Dok?
Nggak matikan Bluetooth-nya.
Oh iya.